Hello, I'm Elise Yoon, and I'm presenting elderly as a predictor for perioperative complications in patients undergoing multi-level, minimally invasive transforaminal lumbar interbody fusion, also shortened as MIS-TLIF. I'd like to thank the Southeast Michigan Center for Medical Education Forum for the opportunity to present this research, as well as my co-investigators, program, and hospital for their help in this project. As the population ages, the number of elderly patients requiring spine surgery will also increase. Elderly patients are considered higher risk and historically have had higher rates of complications with spine surgery, particularly those more extensive surgeries that require longer operative time, more time under anesthesia, and greater blood loss. Minimally invasive techniques allow us to achieve the same results as a traditional open surgery with a smaller procedure. However, currently there are very few studies on outcomes in elderly undergoing more extensive, meaning multi-level MIS-TLIF. Traditionally, spine surgery is done through an open approach. This requires a larger incision, more retraction on soft tissues, and detachment of paraspinal muscles. Minimally invasive techniques and X-ray allow for spinal cord or nerve decompression through a small incision, as well as placement of screws and rods percutaneously, resulting in less blood loss, less pain and opioid use, and faster time to recovery. In this study, we aimed to identify perioperative and postoperative complications in elderly patients versus non-elderly patients undergoing multi-level, minimally invasive transforaminal lumbar interbody fusion. Secondarily, we sought to identify predictors of these complications. This was a retrospective review of 467 patients who underwent multi-level, 2 or more levels, MIS-TLIF from 2013 to 2017 for degenerative conditions, so we excluded trauma, infection, and tumor. Patients were divided into an elderly group, 70 years and older, and a non-elderly group, 50 to 69 years old. Complications were classified as major or minor using the Carrion classification. We used a backward multiple stepwise logistic regression to identify predictors of complications. We also did a subgroup analysis of the elderly cohort, and a p-value of less than 0.016 was considered significant with Bonferroni's correction. There were 152 patients in the elderly group and 315 in the non-elderly group. The elderly group had significantly more patients discharged to rehab, longer length of stay, and higher Charlson Comorbidity Index and ASA scores, with ASA being a measure of surgical risk. The most common minor complications were UTI, urinary retention, anemia requiring transfusion, and confusion. The elderly group had a significantly higher rate of UTIs and urinary retention, and there were no significant differences in major complications between age groups. 42.3% of the elderly group had a complication, with 7 patients having a major complication, and 27.6% of the non-elderly group had a complication, with 5 patients having a major complication. Our multivariate analysis demonstrated that age was not a predictor for either major or minor complications. Comorbidities and length of stay was a predictor for all complications, and duration of surgery was a predictor of minor complications. The subgroup analysis of the elderly patients trended toward significance for length of stay and Charlson Comorbidity Index as predictors of major complications. However, it did not reach statistical significance. Age was not a predictor of complications, despite the elderly group having significantly higher comorbidity indices and longer lengths of stay, both of which are 2 factors that were predictors of complications. We did not see significance for these measures as predictors within the elderly group because we did not have sufficient power within the subgroup analysis. Surgical risk is more so a reflection of physiologic age rather than chronologic age. Therefore, attention should focus on optimizing modifiable comorbidities of surgical candidates and limiting operative times. With length of stay, we are not able to say whether patients stay longer due to complications or that they are more likely to have complications as a result of a longer stay, as we did not collect data on the exact timing of complications or on other information such as insurance requirements prior to acceptance at a rehab facility or social factors that may contribute to length of stay. Age is not a predictor for complications in those who underwent multi-level, minimally invasive transforaminal lumbar interbody fusion. Therefore, age should not be a deterrent when considering a patient's surgical candidacy. Attention should rather be focused on optimizing comorbidities and operative time. Here are the references for my PowerPoint. I want to say thank you again to the SEM CME Forum for the opportunity to present this research. Thank you.